All right, well, we're going to get started. And we have our last speaker with us, Dr. Kaplan. We're so pleased to have you here with us. Dr. Kaplan is the associate professor at the Medical Center and practices comprehensive ophthalmology at Kellogg Eye Center. She joined the faculty in 2011 and currently wears many hats. Currently, she is the co-director of the medical student education for the Kellogg Eye Center, the Associate Residency Program Director, and the Kellogg Eye Center Operating Room Medical Director. She recently took a position in the UMMS Office of Student Services as Director of Career Advising for medical students, so certainly has a lot of hats. And she's going to be sharing with us about vision and ocular health as we age. Thank you.
Thank you so much. Thank you for the opportunity to speak today. It's been a while since I was able to speak to you, and it's nice to be in person. So thank you so much for being here, and thank you to the people watching online. So today I'll be talking about our eyes and some of the conditions that we like to monitor for as we age. But it's important to get a good understanding of the eye. So I'll talk about the anatomy of the eye, the structures, and how we use our eye to see. We'll talk about common decreases of vision, common causes of decreased vision, as well as common causes of vision loss, and then just generally how to keep our eyes healthy. So this is the eye. I talk about the eye and the structure of the eye often with patients because it's really important to understand the structures in order to understand what's going on with our vision as it changes over time. So if this is an eye and I were to cut it in half, here's the front of the eye, here's the back of the eye. I always describe this as kind of like a camera. So as light enters our eye, it goes through this front surface of our eye called the cornea, which is like the clear window of our eye, through the aperture, which is created by the pupil or the colorful part of our eye, and then enters through a lens. This lens is clear when we're born. These structures, the cornea and the lens, help to focus the light to the back of the eye. The back layer of the eye, generally is the retina, but there are parts of the retina that you may be familiar with, one being the macula, which is the center part of our vision, and then the very center of the macula we call the fovea, which is right here. And the fovea is where the light is focused, and that is where images are then processed, and the message is sent to the optic nerve right over here. And the optic nerve sends messages to the brain, travels through our brain to the visual cortex, so the occipital lobe in the back of our brain, where our brain then interprets the image. It's quite fascinating, the whole process. It's amazing what we're able to accomplish. And so there obviously are conditions that can affect every part of our eye. And because of that, people think, oh, ophthalmology, it's just the eye. But actually, we become very subspecialized within ophthalmology. So just some of the specialties that we have. I'm a comprehensive ophthalmologist. I like to describe it to medical students. I say I get to do everything with the eye. And then I work to the point where I think either the patient would be better served by a specialist or they may need specialty surgery, and then I'll refer into the specialist. My practice, I do cataract surgery. I also teach cataract surgery, so I'm in the operating room a lot, but I'm only doing cataract surgery. We have cornea specialists, which again are just focusing on the front window of our eye as well as the lens in the eye. Glaucoma specialists, we'll talk a bit about glaucoma and what it entails. They're dealing with really what the optic nerve and the health of the optic nerve over time. We have retina specialists. oculoplastics, neuro-ophthalmologists, which again, these are the people who are kind of focusing on the space between the back of the eye and the optic nerve and the brain and that space in between. We have pediatric ophthalmologists and strabismus surgeons. These are actually the common condition that can affect both children and adults is eye misalignment. So it's not uncommon for us as adults to develop eye misalignment, and I will refer to a strabismus surgeon. It just so happens that they are all located in the pediatric clinic. So I always warn people that when you go there, it's going to see the pediatric clinic, and you're sitting with the children, but both children and adults are suffering from eye misalignment. You're in the right place. And fascinating, I mean, even within each specialty, we have subspecialists. So there are retinal dystrophy specialists, we have ocular oncologists, we have ocular pathologists. I'm blanking on how many other specialists we have. So I'm very fortunate to work at Kellogg Eye Center because we have so many amazing resources. I have great colleagues, but I think we're able to deliver great care. And so I encourage you all to come and see us. So first question, what is the most common cause of impaired vision in the world? I don't know if you saw the slides beforehand, but it's uncorrected refractive error. Essentially, the need for glasses. And in a country like ours, we're fortunate that we have multiple ways to correct refractive error. So we can correct with glasses, contact lenses, and even refractive surgery like LASIK. Some of you may be familiar with. So I just want to talk about refractive error. What is it? Because I see a lot of glasses in here. A lot of us are wearing glasses to correct for our refractive errors. So in perfect state, okay, when the eye is functioning and does not need correction for focusing light, we call that emmetropia, where the light is entering the eye, passing through the cornea and lens, and being focused directly on the fovea of the retina, okay? This is a person who does not need refractive correction. But a lot of us, myself included, are myopic. The common term you may have heard is nearsighted. We don't love this term because it's incredibly confusing to people, so we try to stick to the term myopia. And that is when there's actually too much refractive power in the cornea and or in the lens. And so the light is being focused in front of the fovea. And that's what I'm trying to show you here, okay? So when we wear glasses, we're actually taking away refractive power for this patient so that we can bring the focus back to the fovea, okay? That is the different than hyperopic refractive error, where there isn't enough refractive power between the cornea and the lens. And so the light's being refracted behind the fovea, thus the unclear, blurry image. And again, so when we put glasses on people to correct for this, we're actually adding power to help bring the focus and shift it to the fovea, okay? Now this is a common term and it's a confusing one, astigmatism. It's just another kind of refractive error. I like to describe it like this. We think of our eye being shaped like perfect balls or spheres, okay? But in actuality, in reality, our cornea or our lens comes to a point, and that point causes the ray of light coming into the eye to be focused to two separate spots. They're not focused in the same spot. And so it can cause a lot of visual distortion. So sometimes people will literally describe distortion to us. Sometimes it's blurriness. And when we're correcting for astigmatism, we're bringing these two rays of light to the same point of focus, okay? Now, you can also have a mix of all of these. You can have myopia with astigmatism or hyperopia with astigmatism. You can have astigmatism by itself, right? There are lots of variations. And then that brings me to presbyopia, which is the loss of accommodation. So when we're young, we are able to bend this structure, the lens. The lens is supported in the eye by these tiny little zonules that are connected to muscles of the eye. And our brain sends a message and says, okay, we're going to read now. And so these muscles flex, and it stretches the zonules, which actually makes the lens bend. And it allows us to bring reading distance material into focus. That is called accommodation. Kids are born with tons of accommodation. I think I have a slide on this. Yep. They have more than 15 diopters of accommodation. They just crank it up. They can do it. They don't even think about it. Their little brains are so smart. A lot of them have smaller eyes because they're smaller. And so they actually, a lot of them are hyperopic. And they adjust to it. They don't even need glasses because they're able to crank in some extra power so that they can see clearly. Their brains do this automatically. Sometimes they crank in so much power to correct for their hyperopia that they are cross-eyed. So parents might notice that their children have eyes that are cross inward, and it's because they're cranking in so much accommodation so that they can see clearly. They're not able to voice that to their parents. Their brains are so malleable, and their lenses are so malleable that they do it automatically. So for these children, we can put them in little bifocals. We give them that added refractive power so that their eyes can go back into normal alignment. And they grow out of it. A lot of them grow out of it. So it's pretty amazing. So as you can tell, as we age, we slowly lose our accommodative ability. And usually right around here, in our 40s, it becomes harder for us to read. And then a lot of us will add in our glasses something like a progressive lens or a bifocal or trifocal. And what we're doing is we're just adding magnification to the bottom of our lens so that we can, since we've lost our accommodation, we can still bring reading material into focus. So I suspect many of us have experienced this personally. Okay. This is I just wanted to touch on this. UMH, which is University of Michigan Health System Services, they have an amazing program there, Dr. Myers, who has actually developed like little refractive lanes in shipping containers, and these shipping containers can be sent all across the world to areas that are incredibly remote. And within the shipping container, they actually have all the equipment they need to make glasses. So we're able to deliver care to areas of the world that may otherwise not have access to glasses and such. So it's a really amazing program, and he's been able to touch many lives just by providing glasses. All right, so now we're going to get into more medical conditions or medical causes of vision loss. And I'm going to start with my favorite, because this is what I think about all day, which is cataracts. So what is a cataract? Again, I describe this as light's coming into our eye. It's going through the clear window of our eye, and then going through the pupil. And then what develops is this clear lens. Let me go back. So this lens is clear when we're born, but as we age, it turns yellow and cloudy, and then we call it a cataract. And the cataract likes to do two things. One, as light passes through the cataract, it acts like a filter. So not as much light can get to the back of the eye. A common thing people will tell me, they don't even realize that they're describing their cataract. They'll tell me, I really love to sit in this one seat in my house to read. And I've noticed that the light in that area just isn't enough. I've had to actually pull in another lamp, or I've changed the light bulb and I went on up on the wattage. They're actually experiencing this, where the cataract is filtering out the light. They're needing more light to accomplish what they used to do with less light. And so they're adapting without even realizing what the problem is, and that is that the lens is filtering out the light. The other thing that cataract likes to do is light comes into the eye, rather than helping focus the light to the back of the eye, it unfocuses the light. So for a period of time while the cataract is developing, we can actually update glasses prescriptions so that the light remains focused to the back of the eye. But at some point, we cannot correct the unfocused light with glasses. And then what we'll tell you is, we're not able to get you to 20/20 vision. We can get you to maybe 20/40 or 20/50 vision, but the cataract is not allowing the light to be focused to the back of the eye. And that's when we start to have this discussion where, like, it might be time to start thinking about cataract surgery, okay? So when is it reasonable to consider cataract surgery? That's a good question. So decreased vision that cannot be corrected with new glasses, and this is important, that the patient feels vision is limiting them from doing what they want to do. I have patients come in, I always enjoy because people say, well, what did you grade my cataract? And that's not the full picture, right? I always describe that I have patients who come in who have incredibly dense cataracts. I think to myself, oh my gosh, how'd they find the chair? They walk in, they sit down, they have no complaints. They're doing fine. Maybe they're not 20/20, but they're safe enough to drive. They are enjoying the activities they like to do. I'm okay watching it. I have no problem. Then I'll have patients who come in with very mild cataracts, but have lots of visual complaints that I think can be associated with the cataract, in which case that might be a reasonable person to have cataract surgery. Because if you're not able to do the things that you enjoy doing, that's a problem. And I want you to be able to continue to do it, the things you enjoy, and I want you to continue to be safe. So those would be the two times where you need those two things. You need to have the cataract. That's my job. I can tell you yes or no, you have a cataract. But then I also like to correlate it with what your symptoms are. And I'm not going to say you have to have cataract surgery just because you have a cataract. You really have to be symptomatic. There are risks to cataract surgery, and I want you excited for cataract surgery. I want you willing to undergo the risks of cataract surgery for the gain. And that's where this conversation that we have comes into play. The other thing that people with cataracts will often complain about are glare and halo when you drive at night. And it makes them feel unsafe. So some of the things that people report to me is they'll say, when I drive at night and there are cars coming towards me, I'll actually focus in on the white line or the yellow line to the left because the lights are so distracting to them. Yeah, that would be a good time to think about cataract surgery because we want your gaze maintained on the road. So if you're experiencing something like that, it would be reasonable. The other thing people will say is, I no longer feel safe driving at night. Some people don't need to drive at night. That's okay. That's not a judgment call. But for the people who need to be able to drive at night, so maybe they are their only driver and they want to be able to go out and enjoy evening activities, particularly in Michigan in winter when we have very short days, driving early morning when it's dark or driving late at night is important to people to maintain independence. And so if they're struggling with that and they're not feeling safe, it's totally reasonable to consider cataract surgery to improve those symptoms. And then this might be the only time where a patient and I might be in slight disagreement. No longer meeting state requirements for the visual acuity test at the DMV. And so there are people who think their vision has not changed, and yet I'm showing progression and that their vision is now not meeting state requirements or approaching the state requirements. They may not meet the state requirements in the future. So I will definitely say this is something that we need to consider because we want to keep you safe. We want to keep you on the road. And so sometimes that's a conversation where we have to have more follow-ups just because I want to make sure that they remain safe on the road and that they're meeting the requirements that the state has set for us. This was an interesting point. So a lot of times, vision changes slowly. Cataracts develop, for the most part, slowly over time. And so colors can change over time. And this was a painting by Claude Monet where you can tell the yellowing and the fuzziness of his painting comes into light. I actually, for the talk, I was looking up Claude Monet and reading about it. It was pretty fascinating. He was really against cataract surgery, but his vision became so impaired that he was, in his right eye, I think he went down to light perception vision. He was so impaired. And when you're only using one eye, you really lose your depth perception. You need both eyes functioning and focused at the same point in order to retain depth perception. So it does become a safety issue. So his doctors, this is a long time ago, in 1922, they were talking to him for years about cataract surgery, and he finally underwent the procedure. It was very different back then. It required weeks of recovery, and so we didn't have lenses to insert in the eye like we do now, so he ended up with a Coke bottle glass. Causes a lot of distortion. Needless to say, he wasn't very happy with it. But he did do paintings afterwards, which were also fascinating and showed the color changes back to like blue hues. And there are books on his work as the cataract during that whole period. So if you're interested, I do recommend it. But a lot of the changes can be slow progressions that we're not even aware of the change. And sometimes when I do cataract surgery between the two eyes, I'll do one eye, 2 weeks later we do surgery on the second eye, people will report, I had no idea. I thought I put up yellow Christmas lights. It turns out they were white. Like they didn't even recognize the color changes until they start doing right eye, left eye comparisons. All right, so what does cataract surgery entail? So there has been incredible progress in cataract surgery. It's an outpatient procedure. So you come in the day of surgery, you go home the day of surgery. You need a driver with you. You can't drive for 24 hours. The two eyes are done about 2 weeks apart. The big restrictions, honestly, I don't think it's too cumbersome. I ask for no heavy lifting, bending, straining for 1 week after surgery. So it really means nothing more than 10 pounds in weight. And then when we take out the lens, we use an ultrasound machine to break it up into lots of little pieces, and that allows us to make a really small incision. And at the end of surgery, the incision is so small that I almost never have to place a stitch or a suture to close the wound. That's how small the incision site is. We do inject a new lens that goes in the eye. And that new lens folds up like a little taco or burrito, and I inject it through, and that incision, it opens up, and I place it in. And the amazing part about that new lens is it can correct or at least limit refractive error or correction after surgery, which means it can minimize the need for glasses correction after surgery, which for some of us would be very different than what we're used to. Some of us have been wearing glasses since we were little. So this can be a very exciting and a big change for people. And the nice thing is that new lens that we place in the eye never has to be removed nor updated. So it stays there the rest of your life. So it's important for you and your physician to really have a discussion about the goals of cataract surgery because you want to be on the same page after surgery. So questions that I always like to make sure I ask people when we're discussing cataract surgery is, do you mind wearing glasses to optimize your vision? Because like me, I've worn glasses since I was a little kid. I don't know if I would recognize myself without glasses. I have no qualms about wearing glasses. So for me, it's fine. I don't mind wearing glasses after I have cataract surgery. Do you like reading without glasses? I was just having this conversation with someone. Because if you like to take off your glasses to read, then maybe you want to retain that ability after cataract surgery. We can put in a lens that corrects distance vision, but that means we take your focal point and we move it all the way out there. You won't be able to see up close unless you wear glasses for reading. And for some of us, that would be a really big change because we're used to taking off glasses and seeing up close. So we want to make sure that you are happy with your decision so that after surgery, you're comfortable. And then the other thing, I always ask people, have you always wanted to wake up and see the clock across the room without putting on your glasses? Because for some people, that's dreamy. That's what they want to do. And so I can try to achieve that goal if that's really important to them. And so there are many lenses on the market. I will touch quickly on this. So there's something called a monofocal lens, which corrects for either distance vision or reading vision. There are toric lenses that we can put in the eye and dial it into place. That can correct for astigmatism. And then there are lenses on the market called multifocal lenses, which try to correct for everything. So they try to correct for distance, intermediate, and reading vision all in one lens. The toric lens and the multifocal lenses are generally not paid for by insurance companies. So it is an investment on your part if you want those lenses. And wherever you go, it differs in how the pricing. But I can tell you it's somewhere between $1,600 to $3,000 an eye for these special lenses. I think the toric lens to correct astigmatism is a wonderful lens, and it does a really good job. I think the multifocal lens is a good lens, and I think for the right person, it can do a good job. But what I tell everyone is that the multifocal lens will not be your 20-year-old vision. There is no lens on the market that will give you your 20-year-old vision, where you could hold anything anywhere and be able to focus it. That is not the multifocal lens. Could it be in the future? Fingers crossed we will get there. But at this time, they're good lenses. But just recognize that the reading distance is 14 inches from your nose, and that will not move. And so there are certain distances. And so you have to kind of know I've had patients who are super tall with long arms, 14 inches is too close for them. That would be really uncomfortable. So things like that you have to think about when we're picking out these lenses. So take-home messages here for cataract, how to protect your eyes. Wear UV light protection glasses. Honestly, a lot of our glasses already have it now. Our car windows have it. They're so smart, they put it in the cars. And so it's really important because UV light can hasten the progression of cataracts. Avoid steroid medications if you can, but if it's breathing, that takes precedence. So you should take the medication if you have to, but if you could avoid it, it's good. Sometimes we're on steroid creams or inhaled steroids for like sinuses. Maybe you want to think about not taking those if it's comfortable to you, but you need to be comfortable. Avoid smoking. Controlling blood sugars. If you're a diabetic, high blood sugars have been shown to hasten the progression of cataracts. And the last thing I always talk about is that there's no vitamin or supplement that's been shown to slow the progression of cataracts, no matter what you read. No study has actually shown that this does help. So what we say is healthy diet like everything else. Everything's in moderation. Okay. All right, I'm going to move on to glaucoma. So what is glaucoma? Again, here we are. Light's coming into the eye. The front of the eye focuses light to the back of the eye. The back of the light takes a picture and then sends a message from the eye to the brain. And the message is sent through this optic nerve, which is like the cable. And glaucoma damages the optic nerve over time so that the signal being sent is damaged, okay? A lot of us think of glaucoma being associated with high eye pressure, but that's actually not the case. We do follow glaucoma with eye pressure. We treat glaucoma by lowering eye pressure, but you could actually have something called normal tension glaucoma, which means you're in the normal range of eye pressure, but you're still having damage to your optic nerve. And so we still need to lower your eye pressure. So you may be in the range of normal, but we need to lower you even further. And so the goals of glaucoma treatment is to stop progression of vision loss. Unfortunately, at this time, we have no treatment to regain vision loss that is lost from glaucoma. So again, our goal is to stop any progression of vision loss. End-stage glaucoma can lead to blindness. This is rare, but it can happen. And it's the blindness where people end up in darkness. So this is one of those things that people really worry about, and we worry about too, because we want to avoid that at all costs. We have lots of treatments for glaucoma. So I always talk about we have eye drop medications. We have many different classifications. We like to combine them. We like to, I don't know if anyone here, we'll put you on drops all day if we can. But they can act to lower the eye pressure through different mechanisms of action. We have laser treatments we can also offer people. Again, same thing, same concept, lowers the eye pressure with the laser treatment. And then finally, we can offer surgical procedures. We like to save those, and we're not going to do surgical procedures unless we're really not successful with drops and laser treatment. Okay. Oh, and I guess what I was going to show you here, so if this is a normal picture, people with glaucoma, we generally think of it being the loss of peripheral vision. And again, because it's your peripheral vision, we don't think about it that much. Like right now, my peripheral vision's all blurry because I have glasses frames, so everything outside the frame I'm kind of ignoring, right? If I were losing that peripheral vision slowly, I probably would not even realize it. So when you go to an ophthalmologist, we look at everyone's optic nerve, and we're looking at the health of the optic nerve. If we see signs that we say, you know, that's a little concerning because that could be a change related to glaucoma, we'll ask you to come back for further testing. And we may follow you as a glaucoma suspect. So that's someone who doesn't have glaucoma, but maybe you have changes to the optic nerve, and we want to follow you over time. Maybe you go into the ophthalmologist or an optometrist and they tell you, oh, your eye pressure is high, so it's that higher eye pressure. They may send you in, and again, we'll follow you with testing over time. Okay, so when you come in for glaucoma testing, we do lots, that's another thing, we like lots of tests for glaucoma. So we'll check your intraocular pressure, we'll do visual fields, and we'll also take a picture test of the optic nerve, looking for thinning of the optic nerve over time. And it's kind of a puzzle when we put this together. We put all these pieces together and we say, okay, you know, we're suspicious of glaucoma, or we might say you have glaucoma. We try to define what kind of glaucoma and the severity of the glaucoma, and that helps us follow you in the future. And all of these tests, we do baseline testing, so as we follow you going forward, we have something to compare it to. Okay. Amazing. They have had amazing innovations in glaucoma surgery recently. So even within, when I stopped training, this is new to the market. This is called an eye stent. So this is a really big picture of it. And this is one of the surgical procedures, but I just think it's just amazing what we're able to do. So the eye stent is a little device that's inserted into the drainage system inside the eye itself. And if this is a penny, this is how big it is on the penny. Isn't that amazing? So we can do cataract surgery and implant these stents, and that can help lower eye pressure. Again, maybe getting patients off eye drops or at least slowing the progression of glaucoma. And again, we have different kinds of procedures, but there's been a lot of innovations in the last 10 years just in this area alone. So I did want to touch on this because if you read your medication insert, you'll have read this. Medications sometimes warn that you should not use the medication if you have the diagnosis of glaucoma. But actually, it's not every kind of glaucoma. It's a specific kind of glaucoma called angle closure or narrow angle glaucoma. So I'm going to try to orient you here. If this is the eye, and here's that clear window of the eye, the cornea, and here's the iris, which is the colorful part of the eye. Where these two structures meet is called the angle. It's pink here. And the angle is where we have a drainage system, trabecular meshwork. So the eye is constantly making fluid inside. These are not tears. This is different. This is called aqueous fluid. Fluid is constantly being made and constantly being drained out of the eye. And when we give you medications, it's to change the either drainage or maybe production of that aqueous fluid. In narrow angle or closed angle glaucoma, literally it closes off. So there is no access, or there's minimal access to the drainage system. These are the medications that can affect the angle closure. So that would be like cold medications. If you have been told you have a history of closed angle glaucoma or narrow angle glaucoma, you should not take those kinds of medications because there is risk. But if you have normal tension glaucoma or primary open angle glaucoma, you're not at risk with these medications. So feel free to ask your doctor if that's a question. Take-home messages here. So important to follow with an eye care provider if you have a family history of glaucoma. We know that glaucoma runs in families, but we don't really fully understand the genetics yet. So we can't say, oh, you have that gene, you're going to have glaucoma. If you have a family history, though, you should follow up and make sure that you're being followed. If you've been told that you have high or elevated eye pressures in the past, if you've sustained an eye injury, so that means if you've had an eye injury which required ophthalmic care, maybe something like an abrasion on the eye would not count, but if you have been hit in the eye with impact and maybe had a hyphema, a retinal detachment, that would be concerning. You can have glaucoma from a trauma like that. So, okay. All right, here we go. What is the leading cause of vision loss in people over the age of 70 in the United States? Good job. Yes, macular degeneration. So what is macular degeneration? So the full name of macular degeneration is age-related macular degeneration. So you actually have to have the age in order to have the diagnosis. If you are young and someone has diagnosed you, so think about this with your family members. If you have someone young in your family and has been diagnosed in their 40s with macular degeneration, they should seek care because that is probably a different diagnosis. It can look like macular degeneration, but they're missing the age part. So over 70, 60s, 70s, 80s, if you have these changes that of macular degeneration, it's likely the age-related kind. So what is age-related macular degeneration? Again, the macula, so this is the retina. The macula is the center part of the retina, and the very center we call the fovea. So, all right, I'm going to show you two pictures side by side each time. I'm just going to orient you here. So this is normal, healthy retina, okay? So this is a color fundus photo of the left eye. This is the optic nerve. These are the retinal vessels. You can see this area right here. This entire area we would call the macula, and then the fovea would be right there, okay? This is a slightly different picture of the same healthy retina, okay? Now, I describe to patients, I say, if we're looking at a cheese pizza, okay, here we're looking at all cheese. In this picture, we're looking at the slice of pizza. We've turned it on its side, okay? So we're looking at cheese, we're looking at the sauce, we're looking at the crust. And when we look at this, we can look throughout the retina at different slices of the retina and see the different layers of the retina, okay? Healthy retina right here. This is what age-related macular degeneration, but the dry form might look like, okay? And what you may notice up here are these soft, squishy, yellow things. We call these drusen. This is a sign of macular degeneration. And then if we were to look at that slice, you can see these lumpy bumpies right here. So I'm going to go back. This divot right here indicates the fovea, the center part of the macula, and you can see this bottom line is nice and flat for the most part. Here you can really see the lumpy, bumpy drusen underneath the retina, and that is dry macular degeneration, okay? So with dry macular degeneration, we have two recommendations. One, to take AREDS 2 vitamins. This is a big study that was done, and we found that people who were on the vitamins had slower progression of macular degeneration than people who didn't have than people who weren't on the vitamin. The people included in this study had moderate macular degeneration. So for anyone with the diagnosis of macular degeneration, I do recommend the vitamin. The question comes in if you have a strong family history. We don't know. Maybe it would help slow progression or prevent progression. But the vitamin is very expensive. It's taken it for years and years. It adds up. So it's not for everyone. And the other thing we recommend would be the Amsler grid. So this is a grid, and we ask that you would take it home. You're supposed to check one eye at a time with your reading glasses on, held at 14 inches from your nose, which is reading distance, and you're looking for changes in the grid. So I have an example. If you were to notice a black-gray splotch or the straight lines suddenly become curvy, wavy, that would be concerning that you've gone from the dry form of macular degeneration to the wet form of macular degeneration. And we treat these very differently. So I'll talk about wet macular degeneration now. So this, again, we're looking at the cheese pizza here, you can tell. This is a hemorrhage in the eye. This is atrophy down here. If we looked at that slice of pizza, so here are the lumpy, bumpy drusen down here, but now we have these cysts of fluid in the retina because there's either hemorrhage or fluid that's leaked out into the tissue. So you have, someone would have wet macular degeneration or exudative. And we treat this very differently. So this we treat with injections of medication into the eye. This is an office procedure. So you would come in, numb up the eye, get the injection, and people can drive themselves home, assuming that their vision is good enough and that they feel comfortable enough, they could drive themselves home. It's incredible. This has saved thousands and thousands and thousands of people's vision. There are downsides to the injections, like everything. So we do something called inject and extend. So we'll inject for a series of 3 over a 4 to 6 week period, and then we see how you do. And if you're doing well, then we say, okay, well, let's maybe extend it out a period of time. But you're coming back for multiple injections. And for how long, we can't give you a date. We don't know. So it is a big commitment on your part to seek care, but it can keep you driving and reading and independent. So it's amazing. So the end stage of macular degeneration, this is called geographic atrophy. So here the the tissue there is kind of essentially gone, and you can see there aren't even lumpy bumpies. They're just kind of nothing over there. That is the end-stage macular degeneration. So the difference I wanted to make here, the point I'm making here is end-stage macular degeneration can be terrible for people because they do lose significant vision. But the vision loss does not leave people in darkness. So it leaves them with poor vision where they may not be able to continue driving, or they may struggle to read, and they may struggle to see features like faces. But it does not leave them in darkness. They can continue to navigate, they continue to live very productive lives. It's different though. And that is different than what I was talking about with the end-stage glaucoma. These are different forms of vision loss. This is what someone with macular degeneration at end stage may see. You can tell that the center has been blacked out. So again, if you're looking at someone's face, you may have to shift slightly off focus to see some of their facial features because centrally they don't have that vision. This is something that I did want to bring up for geographic atrophy or end stage. In 2023, they did FDA approve Syfovre as well as another medication, Izivray. I don't use these medications myself. But for the right patient, it can be helpful. And it has been shown that that can slow the progression of geographic atrophy by a matter of months. So it's not slowing things tremendously, but it does slow it for months. There are drawbacks to the injections. And so you really need to talk to your physician about whether the benefits of the injections outweigh the potential complications. So how to protect your eyes with macular degeneration. Follow with an ophthalmologist if you have a family history. Again, we know that it runs in families. Again, wear UV light protection glasses and avoid smoking. All right, so this one, our last one. Let me just take a quick look here. Okay, so the leading cause of preventable vision loss in the United States. Any thoughts there? Diabetes. It's diabetic retinopathy. It's so important that diabetics follow with an ophthalmologist. So diabetics over time can develop unhealthy blood vessels. Essentially, the blood vessels, the cells around the blood vessels stop functioning as well. So you can have leakage of fluid, swelling of the tissues. Eventually, the blood vessels can stop functioning appropriately and the eye can start growing unhealthy blood vessels. So I'm going to show you a few examples here. If this is a retina without diabetic retinopathy, so a nice healthy retina here, this is a retina with what we call non-proliferative diabetic retinopathy. And you can tell this is, again, the retina, this is the macula. These yellow spots are what we call hard exudates or lipids that are leaking out into the tissue of the retina. Very small up here are microaneurysms and hemorrhages. And this can cause swelling of the retinal tissue and cause decreased vision. So when we screen people, we always say, come in for your annual diabetic exam, and we're screening for diabetic changes like this. We can treat certain changes. The most important thing people can do is good blood sugar, blood pressure control. So we always emphasize that with people. And the way we can treat it, sometimes we can use a laser, sometimes we'll do injection of medications in the eye. This is a proliferative diabetic retinopathy, so this is vision threatening, and it can be mild to significant vision loss. And it does require treatment, again, sometimes with lasers or injections, and these patients would need very close follow-up to ensure that they don't have permanent vision loss. So what you can do to protect your eyes, again, controlling blood sugar, blood pressure, see your ophthalmologist regularly, at least yearly, unless they say come more frequently, and then following with your primary care physician or an endocrinologist regularly for blood sugar, blood pressure control. Okay, so the big take home I think you guys all picked up was wear sunglasses. Don't pick up smoking if you are not a smoker. If you're a diabetic, try to control your blood sugar and blood pressure. And then also following with an ophthalmologist regularly if you have a family history of macular degeneration or glaucoma. And if you have diabetes, you should be following annually at least with an ophthalmologist. I did want to just say, if you had any, you just want to look and read more about things, the American Academy of Ophthalmology has great videos and photos, descriptions. So I would encourage you to go there as a resource if you wanted to look up and read more about it. Thank you. I really appreciate your time.
That was a fantastic presentation. Thank you so much.
Thank you.
I have a kind of a comment question, and I hope I don't get too emotional with this, but back in 2015, my late husband had, they decided he was going to Kellogg, and he had a wonderful doctor. I don't know if he's still there, Dr. Hood, I think. Yeah, Thomas, was that us? Yeah. And Keith had developed cataracts in one eye more than the other. He had been a heavy-duty smoker for years. I was learning all the things you don't do. And he probably was pre-diabetic at the time. And he had glaucoma, they discovered later. So this was September of 2015. And the doctor said, oh my gosh, they did it, but it was a tough cataract removal. And then we went back the next day. Everybody's exclaiming how wonderful their vision was, except Keith, he wasn't. And he dutifully did all the eye drops and everything. the next thing, a few months later, he's calling me on a Friday at work. I worked in the main hospital down the street, from Kellogg, and he said, oh, they want me to have emergent retina detachment surgery. So is that very common? You said there are some dangers with cataract surgery. Is that like a potential danger?
Yeah, so I can talk about the risks of cataract surgery. I don't know the timing. Sorry, what did you say the timing was for the retinal?
He had the cataract surgery like September 10th of 15. I'm pretty sure I'm a pretty big date person. And then I was due to retire the end of December of 15. So I thought, at least, Keith, you didn't spoil the, my my party. So it was early December
Yeah.
when he's at Kellogg. And, so I hurried over.
Sure.
He had driven there separately, and long story short. And then he coped with that pretty well. Managed to rig a TV so he could watch it, and they gave him all the, and dutifully followed that. And then fast forward to and they decided, there was no need to do the next surgery on the other eye, because it wasn't as bad. And then right after he was diagnosed with lung cancer in September of 18, they said, well, maybe you could, get your other cataract done. So long story short, he had that in October. And then 2 weeks before he died in December of 18, they brought us to Kellogg. He was going to have the crazy retina thing with that eye, and then they just decided it was too dangerous. So.
Yep.
At least he's not having that problem anymore. Thank you.
No, I'm sorry. Thank you. So there are risks to everything we do, including cataract surgery. Risks of cataract surgery include bleeding and infection. These are rare risks. So I usually state 1 in 2,000 to 3,000 cases can have a bleed in the eye, a massive bleed in the eye, or infection in the eye. And those can be vision-threatening conditions. About 1 in 2,000 cases can have a retinal detachment. Typically, we think of it happening in a more like a 21-day period after cataract surgery, so it's more immediately after cataract surgery. We talk about the risk of, so when we remove the cataract out, we take it out in lots of little pieces. Sometimes a piece of the cataract can go to the back of the eye, and if that happens, a second surgery is required. We state about 1 in 350 cases can have that complication. And then we talk about swelling of the cornea, which is the front window of our eye, and swelling of the retina. Those are generally just mean a longer healing period. So instead of the 4 weeks traditional healing period that we talk about, maybe it can take up to 12 weeks for people to heal from cataract surgery. And during that period, the vision can be blurry, but oftentimes they recover excellent vision at the end of that. Those are general risks. So I can't speak specifically to your husband, but retinal detachment is a risk. There are also certain eyes that are at higher risk for retinal detachment. So people who have high myopia, who are very nearsighted, are in higher risk than the general population for retinal detachment. And so that could also play a factor into things.
My question is about the AREDS preservision.
Yeah.
You mentioned in that slide that it might not be that helpful for glaucoma.
For glaucoma?
Or for people who have glaucoma. There was a
Sorry, I'm
mention of
going to
it.
go back. The AREDS
So what do they use AREDS preservision for? Is it really necessary for everybody who's got eye issues, or?
No, it's only necessary for people with the diagnosis of macular degeneration. So it's not intended use is not for people in general use, like cataracts or glaucoma. You do not need to take AREDS 2.
I have a question about the halos that you said were a good indication to have the cataract surgery.
Yeah.
I continue to have halos after the cataract surgery.
Yeah.
Is this part of aging?
No, there are certain people and certain eye conditions where halos can occur. So the cornea, that front window of the eye, If you have dry eyes, it can cause glare and halo. If you have something called Goutte or Fuchs corneal endothelial dystrophy, that can cause glare, halo after cataract surgery. Some of these specialty lenses, like the multifocal lens, are known to cause glare and halo after cataract surgery. So there are lots of different reasons. Probably good to bring it up to your ophthalmologist and have them take a good look and see if they can problem solve.
What is the cause of ocular migraines?
So what is an ocular migraine? I think we're familiar with the term aura, where people will have scintillating scotoma, which is like, people describe them as black and white flashing lines or fuzzy TV screen. Generally present in both eyes, but can be more prominent or noticeable in one eye. Generally present with eyes open or closed. So if you have an aura and you close your eyes, you should be still seeing it. They can move from your visual field, move around, I should say, your visual field. So they're really disconcerting to people, understandably so, because they're having visual symptoms, but nothing's right there. Nothing's causing it. So what's happening is a firing of neurons or a firing of cells in the brain in the visual pathway. So we often think of migraines causing head pain or headache, but these are the same idea. It's in the brain. It's the firing of neurons in the brain, but it happens to be in our visual cortex or our visual pathway. And so it causes these visual symptoms. They should last less than 60 minutes, and there should be some kind of frequency or pattern to them. Once you kind of know your frequency or pattern, if it deviates from that pattern frequency, so it's increasing in frequency and it's lasting longer in duration than 60 minutes, then we'd want to know about it.
Question about AMD and its progression. Does wet happen automatically without preceded by dry? Does wet ever go back to dry? If you had one or the other, which would you pick to have?
These are great questions. I actually ask my med students this every time. It's a trick question. That's why I ask it. Okay, so you likely have dry before you have wet, but sometimes people have no idea until they lost vision. They go to the ophthalmologist and they say, oh, you have wet macular degeneration. Probably had dry, right? You can go from wet to dry. That's possible, and actually you're probably heading towards the geographic atrophy or end stage of macular degeneration. And then what's better? So let me back up. So 20% of people with dry macular degeneration will convert to wet macular degeneration, okay? I would say they're both vision-threatening conditions, dry and wet. Dry macular degeneration, we say take a vitamin and watch at home on an Amsler grid. For wet macular degeneration, we can offer a treatment. The treatment, though, is we don't have an end date, and you're coming in for injections in the eye. So I don't know the answer to what is better. You know, if it's my eye and I want to keep my independence and drive and read, yeah, the injections seem like maybe I would want to undergo that. There are people who choose not to undergo injections, understandably so, because it's a big decision to make. So I don't think there's a real answer there. Sorry.
Okay, this question is coming from our online participants.
Yeah.
What are the possible common follow-up procedures post-cataract surgery if vision is deteriorating?
Yeah, good question. So about 20% of people after cataract surgery can have a membrane grow on the back surface of the cataract, and we have a long name for it. It's called a posterior capsular opacification, or PCO. If you are in the 20%, you have this membrane grow, and oftentimes people will say to me, I feel like the cataract's grown back, or I have the same symptoms, or I'm having the glare and halo again at night. Then we can talk about a laser procedure to remove the membrane. It's not surgery, so we don't go to the operating room. People drive themselves to the clinic They sit at a machine, just at like a slit lamp machine, just like I have in that clinic. They'll see a bright light. The procedure itself takes 5 minutes. People drive themselves home, and they usually tell me that about 24 hours after the laser, they saw an improvement. So it's a pretty straightforward procedure, and it's not surgery.
Yes, I have a comment and a question. I was not really noticing any visual issues, but I was told it was advisable to go ahead and get the cataract surgery because it becomes harder and more apt to shatter, and therefore, what you talked about, one of the complications could be as you age. And so you shouldn't wait till you're too old to do it. And then I also had a question in terms of, does everybody as they get older have drusen's?
Not everyone has drusen. That was an easy one to answer. No, not everyone has drusen. But you can also have drusen and not have macular degeneration. So, the other question, so everything is complex, right? So there are certain kinds of cataracts that I would agree would be that we should consider taking out sooner rather than later, particularly in conditions called pseudoexfoliation syndrome. And it's true, a cataract or a lens that's been sitting there 95 years is very different for me to take out than a cataract that's been sitting out there for 65 years. And it is a more difficult, complicated surgery at 95. It's also someone that might have, it just might be a harder recovery period because at 95 it just might be more difficult to undergo an outpatient surgery. So I do understand that. I think it's still important to have the conversation of what are your symptoms? What's your life like? What do you enjoy doing? Are you able to do the things you enjoy? Because again, I want to make sure that if you're going to undergo the risks of surgery, you're going to get the game.
Okay, question I have is the visual field tests.
Oh, yeah.
They always do. So I had one maybe 6 months ago, maybe a year ago, whatever. Then I had another one 6 months. My ophthalmologist says, oh, I don't like that. Something's going on. So I have another one coming up the end of May. What does that mean?
I know this story very well. So I'll tell you, no one likes taking a visual field. It's an interactive test, meaning it takes participation. Unlike a picture, right? You have to participate. Yeah, but if you have a really bad night's sleep, if you're having back pain, if you're worried about your neighbor, if you're whatever it is, and you're distracted, it affects the test. There's a whole subjective side to this visual field test. So I will do. No, but I've done the same. So oftentimes what we're doing is if I see something and I say, that looks different, maybe I'm concerned, I want to repeat it. I'm repeating it to confirm the change. And I'll tell you, a lot of times it goes away the next time we do it. And I say, oh, it's nothing to worry about. I'll see it again and we'll repeat. Sometimes it does confirm the change, in which case I say, okay, now we have to start thinking, what should we be doing next? So that's really what they're doing. Likely, if they're following you as a glaucoma suspect, then it's likely something they saw that they said, that was different. I don't have a good explanation. Let's repeat it and confirm it. Because we don't want to start drops unless we have to. Yeah, so we don't want to have to change things, though, unless we have to. We want to make sure it's a true deficit and not just like a bad night's sleep. Yeah.
So I have a question about, you had talked about glaucoma, with normal pressure.
Mm-hmm.
So I'm someone who's had those lovely eyeglasses since I was little, and I've had both cataracts taken care of at a younger age. But I'm thinking about all the testing I continue to do. How do you diagnose the normal pressure? Because I get the puff and I do the visual things and whatnot. So I was more curious about that.
It's more about setting a baseline for your eyes. So we would say, okay, your eye pressure runs in this range, which happens to be in the normal range, but for your eyeball, it's too high, and we need to lower the pressure from your normal range. How do I know? Well, the puff in the blue light test, all those things are giving me a pressure reading, and we're following those pressures over time, right? And so we're watching the optic nerve to see if there are changes to the optic nerve over time. If we lower the pressure in the eye, we again repeat the test. And our question is, and now that we've lowered the eye pressure, are you continuing to have changes to the optic nerve of your visual field? Yeah.
Hi. My mom has macular degeneration. I think the dry versus the definition. She doesn't have problems like reading, seeing the letters, but they swim around. They move. So I wondered, and we go to her doctor and nothing, they don't really seem to have an answer to that.
There's probably not much we can do about the swimming letter, sorry.
Yeah.
Okay, this will be the last question.
So you go to your ophthalmologist, and he says, oh, it looks like you maybe have AMD, hands you the chart, you see no perturbations.
Okay.
One eye goes, boom, dry.
Okay.
What are the odds, what's going to happen to the other eye? Because at one time they looked both similar. Could it go wet? I mean, what's the probability they follow
There's a higher chance that the other eye will follow suit.
suit? Thank you.
So our suspicion goes up.
But I'm saying, could the other eye go wet just instantly, and the other eye still stay dry?
Oh, yes, that could happen.
So you have, it's just prediction that the other eye is going to go, but not what it's going to do necessarily.
True, and we don't know which form it'll take.
Yeah, that's right. Okay.
We come up with all these theories, but at the end of the day, we don't know. We watch.